Welcome to our case presentation from the Edinburgh students with help from Dr. Philip. My name is Gordon and I'll go through the case history. And from my colleagues, Rebecca and Fraser will take over for the theoretical part of it. So our patient is Mr. N.M., a 73-year-old male, retired farmer, serostatus negative, who was admitted on 24th of January this year. His symptoms and presentation to KCH was swollen legs, facial swelling, after lying down for an onset of symptoms over 12 months. He had a 3-week history of shortness of breath, worse on exertion and on lying down, had not passed stool for a week, and had a week's history of reduced urine output of dark urine. So, further to his history, the only other history of note was an extensive smoking history and a previously heavy drinking lifestyle. The only medications that was documented to be using was ibuprofen intermittently for his headaches. Of note, one of the side effects of NSAIDs is fluid retention, and he had no drug allergies. In cardiovascular inquiry, he had shortness of breath, exacerbated by lying down, exertion, swelling of limbs in the face, and no other positive findings. In systemic inquiry, the positive findings of note in respiratory system was increased respiratory effort with shortness of breath and exertion. In gastrointestinal, the failure to pass stool for a week. On GU, it had decreased urine output, and there was no other positive findings in inquiry. His examination findings were as follows. The remarkable ones being the blood pressure being 140/60, the increased work of breathing, cool peripheries, finger clubbing, and wasting. On peripheral examination, it was cool to touch, finger clubbing, and there was bilateral pitting edema to the level of the knees. And on the face, there was facial edema. Other examination findings were as follows. Respiratory examination, increased work of breathing, bibasal dullness and percussion with bibasal crackles. Cardiovascular examination of note was a displaced apex beat, heart sounds 1 + 2 + 3, bibasal fine crepitations, and a raised JVP. So, diagnostic summary: 73-year-old male presents with facial swelling and shortness of breath on a background of chronic leg swelling. On examination, you have signs of chronic disease, which include wasting and finger clubbing, and signs suggestive of fluid retention and displacement of the apex beat. So, differential diagnosis: there was 4 main complaints: that of edema, breathlessness, constipation, and oliguria. And heart failure was a differential for each of these symptoms. So the overall impression was that of heart failure. The etiology behind it was thought to be COPD and hypertension. And by using the New York classification of heart failure, we thought you'd be class 3 due to his limited level of functioning. So acute management of this patient: the first thing to do would be sit him upright, give him oxygen therapy, establish IV access in a 12-lead ECG, and to give IV furosemide 80 milligrams slowly, to instruct the patient to restrict fluid and salt intake, to admit the patient and to monitor his response to the treatment. So the clinical course: whilst in the ward, the patient collapsed while sitting up after being given furosemide and was found to have a low blood pressure. So the furosemide was stopped and conservative measures were continued. These are investigations that are relevant to be done in this case. The positive findings were that of the chest X-ray with cardiac enlargement, bilateral pleural effusions, venous congestion, and hyperinflation of the lungs. There was an abnormal ECG with LVH and sinus rhythm with ventricular ectopic beats. Echocardiogram showed thickened leaflets of the mitral valve, left pleural effusion, and an ejection fraction of 45%, which is reduced compared to normal. So over the next few days, his blood pressure remained low, ranging from 85 systolic to 100 systolic. So he was began on digoxin with a loading dose and thereafter a maintenance dose. And he began to recover and his blood pressure began to pick up. And once this happened, captopril was started, 6.25 milligrams BD. So in terms of the long-term management of this patient, he was discharged on the 3rd of February in response to the patient's request. He was further counselled about fluid and salt restriction. He was discharged on captopril 6.25 mg BD and digoxin 0.25 mg OD, with a view to reviewing in outpatients in a week's time. He was counselled about the signs and symptoms of deterioration in his condition and advised to present to the KCH in response to these. I now pass over to Fraser and Rebecca to discuss the theory.
Thank you. So myself and Rebecca will discuss what you need to know about heart failure. So to begin with the definition, heart failure can be described as when you've got a cardiac output and blood pressure which are inadequate for the body's requirements. Heart failure can be classified in several ways, for example, acute versus chronic classification. You can have left heart failure or right heart failure, or a combination of these, which is called congestive heart failure, and that's more of a symptomatic classification, which Rebecca will talk about later on. And there's also the New York classification, which Gordon discussed briefly, which we'll talk about more later on as well. So the epidemiology of heart failure in Malawi, we had a search and we found that cardiovascular disease accounts for 7% of deaths in men and 9% in women, and that was from the World Health Organization in 2002. However, up-to-date data on the prevalence of heart failure in Malawi and other sub-Saharan countries we could not find. In terms of the etiology, any pathological process which injures the heart can cause heart failure, and this is quite an extensive list of varying etiologies, for example, infarction, valvular disease, various infective processes, arrhythmias, hypertension, etc., etc. But in terms of sub-Saharan Africa, 90% of heart failure cases is caused by either rheumatic disease, cardiomyopathy, pericarditis, hypertension, pregnancy and chronic lung disease, or cor pulmonale. So the pathophysiology, as I said, any form of pathology which can damage the heart can cause heart failure. This obviously leads to a decrease in cardiac output, and initially this will lead to a sympathetic activation which may initially compensate for the decreased cardiac output. However, in the long term, this leads to cardiomyocyte apoptosis and further perpetuates the cardiac damage. The decrease in cardiac output also causes a decrease in renal perfusion and subsequent activation of the renin-angiotensin-aldosterone system, leading to sodium and water retention and vasoconstriction, which again further perpetuates cardiac damage. So when managing heart failure, it's all about trying to break this vicious cycle of decline in cardiac function.
So moving on to clinical features, these can be separated into right heart failure or left, or indeed both, as Fraser has mentioned in congestive. With right heart failure, it's symptoms of venous congestion. So you would get peripheral edema, raised IVP, hepatic congestion and GI congestion. With left pump failure, there would be symptoms of decreased cardiac output. So they would experience pulmonary edema and have dyspnea when it's worse when lying down. They may have poor exercise tolerance, may experience a cough, and most likely have frothy sputum with that. They may also have cool peripheries. When we're looking at acute versus chronic, acute, similar etiology in initial investigations, but it develops much quicker over minutes or hours, and it's a medical emergency. With acute, the history is important because often you'll find that there's a preceding event, or that you'll find they have chronic heart failure and this is an acute decompensation. So the patient will be more acutely unwell and they'll have sudden onset of dyspnea, and again they'll have a cough and frothy sputum. Signs to look for would be agitation and sweatiness, tachycardia, tachypnea, cool peripheries, and on auscultation you may find a gallop rhythm or bibasal crepitations. In terms of chronic, they have a much more relapsing or remitting course. The main symptoms experienced are more poor efferent tolerance, again with dyspnea and peripheral edema. Signs are quite similar, however with the addition of hepatic congestion and ascites. In terms of the New York classification, it's a classification used worldwide and it's useful to assess severity and response to treatment. It's from 1 to 4, with 1 being that there's no limitation from their symptoms on their everyday activity, and 4 is when they can't undertake any activity without experiencing symptoms, and they may also have symptoms present at rest.
So when you're investigating a patient with heart failure, one of the main investigations would be, for example, an ECG. which might allude us to the etiology of the heart failure. For example, the CCG on the left shows Q waves, which is indicative of a previous MI, which can cause heart failure. The other ECG on the right shows left ventricular hypertrophy, which may be due to hypertension, which can also cause heart failure. The chest X-ray is also an essential examination. Classic findings in chest X-ray: cardiomegaly, prominent upper lobe vessels, pulmonary edema, Kerley B lines, and pleural effusions. And then another essential investigation would be a cardiac echo, which can allude us to the ejection fraction, the wall motion, and various other valvular causes which can lead to heart failure. And certain blood tests, mostly FBC and BNP, if that's available, can also help allude us to the cause or the complications of heart failure.
Moving on to management. So for acute pulmonary edema, it's a medical emergency, so it needs to be treated with urgency. And you've got to sit the patient up and give them oxygen, establish IV access, and give furosemide as quickly as possible, and monitor their vital signs while doing this. If they don't improve, you have to give them more furosemide and also consider moving them to HCU or ICU if that's possible. For chronic, the management's a little bit different, with the aim to relieve symptoms, limit the progression of the disease, and try and increase their quality of life. So you'd want to treat the underlying cause if they've got hypertension or anemia or anything. Avoid exacerbating factors, and also try and counsel them into lifestyle changes such as stopping smoking and exercise and better nutrition. In terms of pharmacological management, diuretics are good as they improve the symptoms, so furosemide. ACE inhibitors can also be added, and they've been found to prolong life as well as improving symptoms, so captopril 6.25 first of all, and then if they remain stable on that, 12.5 BD. Digoxin can be used if diuretics and ACE inhibitors don't control it, or if the patient is in IF and the dose is indicated. With regard to prognosis, we could only find in the UK that 50% die within 2 years, and these are mostly from ventricular arrhythmias or MI. We did look for what the prognosis was here in sub-Saharan Africa, but we couldn't find, so maybe you could.
Thank you very much for listening. Any questions?